Doesn't matter.
Oh, I see.
It's recording? Alright, good morning everybody. We're going to start off with a little video, courtesy of
They want those beds filled and emptied. They don't want women hanging around in the labor room.
Technology is technology. It's not stopping. So if you're going to have good stuff, you might as well use it to get the best outcome.
Maternity care in the United States is in crisis.
People don't have the information. Medical decisions are being made for monetary and legal reasons, not because they're good for the mother and the baby.
This is Pitocin, which is the medication given through the IV that causes contractions.
Just check that she's on PIT. Just make sure that she's on PIT. I asked to keep upping the PIT. And if you're uncomfortable, we can always give you more.
Is this an improvement, or are we making things worse?
How often do you get to see a fully natural birth?
Rarely. Almost never.
Everywhere else in the world, you see midwives attending 70 or 80% of all the births, and the United States stands alone.
You want to talk big lobby, big dollars, they can kind of call a lot of shots.
Accusations tonight that some hospitals are not being upfront with patients who are expecting a baby.
Cesarean is extremely doctor-friendly. It's 20 minutes, and I'll be home for dinner.
Basically, what the medical profession has done is convince the vast majority of women that they don't know how to birth. If I could do that, I could do anything. To me, that's the power of birthing, and that is what we are taking away from women.
It wasn't an illness. It wasn't something that needed to be numbed. It needed to be experienced.
It was the most adventurous day I've ever had in my life.
I don't even have, a diaper. I don't even have that.
I have to get there. I cannot have another contraction in this taxi cab.
Switch on a light switch, and you go to the moon.
This is what I was after. This is what I wanted for my child.
Nothing compares to the privilege of giving life and the responsibility of that. Nothing.
Oh my God! 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 Hi. Oh my God! How are you? Sure did.
So that is a trailer for a video by Ricky Lake, who made sort of a documentary on her experience. She had one birth in a hospital and she had one birth at home, and she wanted to compare and contrast the different methods of birth. So I decided to give a talk here called Planned Home Birth: Profanity or Profane or Sane. It's a very, very hot topic now, very debatable, depending upon whom you ask. So the reality is, it really depends upon whom you ask. And as you were going to thank Dr. Gross for showing me the business of born. It's actually, you can see the whole thing on YouTube if you want, and it's actually pretty interesting. So, how many people here would feel comfortable with a home birth in the following patient? Anybody? Home birth? How many allowing it? Somebody's choice. About one prior. Okay, correct. Yeah. Just feel comfortable with it. Just, somebody's asking your opinion. How many would about one prior C-section at term? What about 5 prior sections at term? Okay. If you go into the literature, you will find different experiences about one of them. The last one actually shocked me. She had 5 prior sections, and she had a VBAC at home, and she actually did okay. But when I started reading it, I started having palpitations as going through her process. So home birth weights vary from country to country. The Netherlands happens to have one of the highest rates of home birth, which ranges anywhere between 20 to 30%, depending upon whom you ask or depending upon the study. The UK has about 3% home birth. Germany has 22% home birth, and USA, down at the bottom, has about 1%, which is about 29,000 home births. So I just decided, it's a very, very big topic. There's many articles out there, both pro and con. And for the first part of this discussion, I'm going to go through some of the more recent articles, very staccato, very point by point, because you can spend an hour on every one of these articles. Then I'm going to go through some of the opinions from different groups, and then actually we're going to open it up to the floor and have a discussion. I do want to thank you very much for coming. We have I asked one of our midwives to come in and give her experiences, and just to let us know that there's differences in the training of different people, and I think that's very important to keep in the front of our minds. This is a study that was published about 3 years ago in AJOG. You'll see a lot of these articles come from AJOG. They wanted to evaluate perinatal morbidity by delivery location. There's hospital, freestanding birth center, and home. And what they did is they looked at the birth certificate data from 2006 from the CDC, and they looked only at low-risk maternal and newborn outcomes, and they tabulated those outcomes. So they had a total of 745,000 deliveries, of which 97% was in a hospital, 6% were at birth centers, and 9% were at home. Compared with hospital deliveries, the home and birthing centers were associated with more frequent, prolonged, and precipitous labor, and home birth experienced more frequent 5-minute APGAR scores less than 7. In contrast, the home and birthing center deliveries were associated with less frequent chorioamnionitis, fetal intolerance to labor, meconium staining, assisted ventilation, NICU admission, and birth weight less than 2,500. Their conclusion, when you put it all together, is that home births were associated with a number of less frequent adverse perinatal outcomes at the expense of more frequent abnormal labors and low 5-minute APGAR scores. So again, what they did is they took the demographic information and maternal newborn outcomes that were selected from the 2003 revision of the birth certificates, and these were used, and you looked at the 2006 data. This 2003 revision is used by 19 states and represents 49% of all U.S. births. So again, the total births in this population in the U.S. was about 4.2 million. 2 million used the new birth certificate data. 745,000 met inclusion criteria. The inclusion criteria is not really clear. And again, most of the people delivered in a hospital, and about 1% delivered at home from this subset. Physicians or midwives attended 5,600 of the 7,400 home births. They measured maternal morbidity in terms of chorioamnionitis, fetal intolerance to labor, prolonged labor, precipitous labor, and meconium staining. And the newborn measures included assisted ventilation for more than 6 hours, birth injury, NICU admission, seizures, 5-minute APGAR scores less than 7, and birth weight less than 2,500 grams. And I just want to, there's going to be a whole bunch of tables over here. Don't get lost with all the numbers. I'm just going to point either with a circle or with an arrow what it's worthwhile looking at. So if you look at the maternal outcome, if you look at the maternal outcome over here you have hospital birth, birthing center, and home birth. So you can see over here the odds ratio for prolonged labor. The home birth was 2.81. The precipitous labor was 3.84. So just remember that 1 is really means there's no difference, and anything greater means that there is that the odds of this happening is higher. And again, this is retrospective data, so we have to keep that into consideration as well. And in terms of the newborn outcome, the 5-minute APGAR score less than 7 was also statistically higher in the ratio at home. Now, if you're going to look at, to be fair, if you're going to look at chorioamnionitis and fetal intolerance to labor, meconium staining, so those assisted ventilation more than 6 hours, so all that was actually less likely to happen for a baby that occurred at home. Granted, you have to take a look at these numbers. Most of these numbers weren't a lot in the numerators, 6, 3, 4, so it's really difficult to know. So their conclusions was that low-risk women delivering out of hospital, where they experienced more frequent and prolonged and precipitous labor. They also have more frequent depressed 5-minute APGAR scores. They're associated with otherwise less frequent maternal and newborn morbidity. Maternal and neonatal perinatal mortality data are really needed because they didn't discuss that, to fully compare the safety and outcomes of hospital versus out-of-hospital childbirth. The limitations of this study is that the completion rates and accuracy typically result in under-ascertainment of prenatal and intrapartum complications. And 20 to 25% of all planned home births require transfer to hospital, and complications are counted as hospital complications. And the data set did not consider maternal or perinatal mortality. So this was soon followed by another article in AJAG in 2010 that did a meta-analysis. So they scanned the literature. They looked at English language peer-reviewed publications from Western nations reporting maternal and newborn outcomes by planned delivery location. And they did 95% confident intervals. So their results is that planned home births were associated with fewer maternal interventions, including epidural analgesia, external fetal heart rate monitoring, episiotomy, and operative delivery. And also, people who delivered at home were less likely to experience lacerations, hemorrhages, and infections. Neonatal outcomes of planned home birth revealed less frequent prematurity, less frequent low birth weight, and less frequent newborn ventilation. Although planned home and hospital births exhibited similar perinatal mortality rates, planned home births were associated with significantly elevated neonatal mortality rates. Their conclusion was that in a low-risk population, in people who did not have babies who did not have anomalies, that less medical intervention during planned home births is associated with a tripling of the neonatal mortality rate. So what they did is they did a computerized search of Medline and Embase between 1950 and 2009, and they did a Cochrane review. And their inclusion criteria was that it has to be from a Western country in English, that's always helpful. Maternal and newborn outcomes analyzed by planned delivery location, and that the results could be presentable in a 2x2 table. And they had, in their data set, they had 340, this was again over a whole bunch of countries, so they had 342,000 planned home births, 207,000 planned hospital deliveries, and they didn't have any maternal deaths reported in the 4 studies. The planned home birth revealed significantly fewer medical interventions, including epidural analgesia, episiotomy, operative vaginal delivery, and women attending home deliveries, again, they had fewer infections, third-degree lacerations, or perineal and vaginal lacerations, reduced hemorrhage, and fewer retained placentas. That's true. That's part of this. The question is, so most of the question is, these people who are at home, do they feel like, oh, okay, I can't do it anymore, I have to go to the hospital? But you're right, it's right. Most of them will not. That's true. So if you take a look over here, just to look over at, you have morbidity and mortality. We're just going to focus over here on the mortality, and they divided it into perinatal and neonatal death. And if you take a look at the non-anomalous babies for neonatal death, the odds ratio for home birth is 2.87. If you look at perinatal death, the odds ratio is the same. Between all non-anomalous babies, and the odds ratio there is pretty close to 1. So their conclusions was that planned home birth is associated with a tripling of the neonatal mortality rate, and that lower obstetric risk among women choosing home birth is likely to overestimate associated benefits and underestimate the risks. One thing I do want to discuss over here is the difference between perinatal and neonatal. So anybody know the difference between those? So perinatal is like what happened, goes up, the area around birth up to 1 week later. And neonatal is the first 28 days of birth. So it's a little bit interesting that they focused on the neonatal deaths and not the perinatal per se, because the perinatal is really those things that happen around delivery. And you can have a neonatal death that happens on day 27 of life, and it'll still be attributed to this column over here. So the Lancet, whose editors read this article, decided to comment on this, and they basically said that women have the right to choose where and how they give birth, but they do not have a right to put their baby at risk. And that hospital delivery should be the preferred method of delivery for high-risk pregnancies, even though hospital delivery is not without risk. And that home delivery is an option for mothers with uncomplicated pregnancies, provided they are advised of the risk involved have one-to-one midwife care and one that has good resuscitation skills, and live in a location that allows quick access to obstetric care. So the response is to the response. So this obviously called a tumult. And the first response, he said that the editorial reports that the meta-analysis included 12 studies and 500,000 births, but fails to mention 3 important points. The first thing is that the comparisons of neonatal mortality, which were specifically mentioned in the editorial, were reported on the basis of only 6 studies and fewer than 50,000 women, which is less than a tenth of those included in the meta-analysis. So if you go back over here and take a look at how many studies here were included, even though overall 12 studies were included, this only included 6 of those studies and over here 50,000 births. The second thing is that the comparison of perinatal mortality rates were based on more than 500,000 women and showed no significant difference between planned home birth and hospital birth. And also the authors of the meta-analysis did not report on the quality of the studies, even though the information is crucial for assessing the reliability of the data. Thing number 2, response number 2, is where does the Lancet, as a quote, perpetuate the misuse of language, irresponsible reporting, and paternalism that dog the home birth debate? Quote, women have the right to how and where to give birth, but they do not have the right to put the baby at risk. What humbug? There's no risk-free birth. Even if home birth was objectively inadvisable, what are you going to do about it? Barring the familial guilt trip and cultural misogyny. The legal right to bodily integrity that men enjoy at all times requires that competent laboring women are not incarcerated in hospitals against their will. Response number 3. Your editorial home birth proceed with caution lays the call to reduce the risk to newborns at the feet of the wrong group. The statement that women have the right to choose how and what to give birth, but they do not have the right to put the baby at risk, follows directly on the heels of statements that attribute the increased risk due to the lack of proper training, access to equipment, and resources. So there's a flaw in the logic to suggest that the solution might be better training, equipment, and resources, and then to suggest that women alone should remedy the problem through their choices. The most effective solution would be a call to action for professional organizations and healthcare institutions to remedy the problems, both for hospital and home births. And number 4, I find your editorial on home births disconcerting. Women have the right to choose when and where to give birth, but they do not have the right to put the baby at risk. These are competing interests that need to be weighed. This statement overlooks the crucial distinction between rights and interests. All people have an interest in the best possible medical care. All people have a right to self-determination, including the right to capably refuse interference to one's body. So the Lancet also mentioned that there was going to be another study that was going to be published relatively soon. And this was the Birthplace in England study. And what this did is this looked again at home births and freestanding midwifery units and obstetrical units, and compared and contrasted the outcomes. So in England, almost all maternity care is provided by the National Health Service and is free. Births outside of an obstetric unit are relatively uncommon. Of women giving birth in 2007, this was in England, 8% gave birth outside an obstetric unit. About 3% at home, 3% alongside midwifery units, and just under 2% in freestanding midwifery units. So they defined an alongside midwifery unit as someplace that a person does not need motorized transport. So if there's a hospital and then attached to the hospital there's a midwifery unit, that's considered an alongside midwifery unit. But if the patient needs to be transferred in a motorized vehicle, then that's considered a freestanding midwifery unit.
I have a question. I know in Ireland a lot of the hospitals are run by midwives and sisters have their backup. That's the same in England.
Who actually runs the hospital? I don't.
Like the labor clinics are primarily run
by
midwives.
I believe that actually is the case.
So then how do you separate out midwifery units from actual hospital use?
I think it has to be their connections to the hospital. I don't know. It's an interesting point. But you can obviously you see that our system is very different than anything that occurs in England or in Europe. So this was a prospective cohort study of patients with planned pace of birth at the start of care in labor as the exposure, and it was analyzed by intent to treat even if they were transferred. So their outcomes, the primary outcomes, included stillbirth after the start of labor, start of care in labor, early neonatal death, neonatal encephalopathy, meconium aspiration syndrome, brachial plexus injury, fractured humerus, fractured clavicle, and the secondary outcomes were neonatal and maternal morbidities that were not included here, maternal interventions, and mode of birth. Their exclusion criteria included elective C-section or C-section before the onset of labor, if they delivered less than 37 weeks, if they had a multiple pregnancy, no prenatal care, or stillbirths occurring before the start of care in labor. They used logistic regression analysis to calculate the odds ratio and confidence intervals for each outcome, and they used a 95% confidence interval for the primary outcomes and 99% for the secondary outcomes. And this is just a graph as to how many people they used. Initially, they were going to use 81,000, and then in terms of the eligible births, they had 79,774, and so 32,000 delivered in obstetric units, 18,000 delivered who had planned to own birth, 11,000 had freestanding midwifery units, and 17,500 were alongside midwifery units. So 79,000 were eligible, 64,000 were low risk, and this just goes over the graph that I just showed. And I want to take a look at the difference over here. This is the graph that discusses how many patients were transferred from the either home of the midwifery or the alongside midwifery unit. And since this is really more of a discussion about home birth, I just want to focus on this column over here. So if you take a look at the nulliparous women, of the 16,000 who were going to deliver at home, so 4,500 were transferred to a hospital. Most of these patients were transferred before delivery. If you compare that to the multiparous women, a total of 12% were transferred. So you have a 45% were transferred from the nulliparous woman, and 12% were transferred to the multiparous woman. So that's something to keep in mind. If you take a look at the incidence of events, and remember this is all conglomerate, this is composite data. So this looks at an incidence of events per 1,000 births. That among the nulliparous women, there was an incidence of 9.3 events per 1,000 births, as opposed to the multiparous women, there was 2.3 events per 1,000 births. It's important to take a look at the obstetric units as well, which is really what your baseline is, and look at and at least in terms of the multiparous women, the number of events per 1,000 units was less than that in the obstetric unit. That's a little bit skewed because you have to take into consideration all the different types of babies and pregnancies, but at least looking at the raw data, it's something that I found somewhat interesting. And this discusses different interventions. And again, it's a busy slide. I'm just gonna to make the point. In terms of some spontaneous vertex birth, so 73% delivered or had a spontaneous vertex birth at home, and 92% or 93% delivered at home vertex. In terms of vaginal breach, it was really they actually delivered at home a little bit more than the obstetric unit in terms of vaginal breaches. Forceps delivery obviously occurred more often at home. And the obstetric unit than at home. Intrapartum C-section, of course, also was much more frequent in the obstetric unit than compared to home. I'll skip that slide. So.
But aren't the people that need C-sections at home being transferred to a hospital?
Correct, but they're analyzed by yes. So this is by intention to treat. And really the patient decided how she wanted to be treated initially. So what is already known on this topic is that healthy women who plan to give birth at home or in a midwifery unit are more likely to have vaginal birth with less intervention compared with women who plan to give birth in an obstetric unit. And there's a lack of good quality evidence comparing the risk of rare but serious adverse perinatal outcomes in these settings. And the study adds is that for healthy women with low-risk pregnancies, the incidence of adverse perinatal outcomes is low in all birth settings. And for healthy multiparous women with low-risk pregnancies, there's really no difference in adverse perinatal outcomes between planned births at home or in a midwifery unit compared with planned births in an obstetric unit. But for healthy nulliparous women with a low-risk pregnancy, the risk of an adverse perinatal outcome seems to be higher for planned births at home. And the intrapartum transfer rate is high in all settings other than in an obstetric unit because you're not going to transfer to yourself, hopefully. So their conclusion is that their conclusion was that they support a policy of offering healthy nulliparous and multiparous women with low-risk pregnancies as a choice of birth setting. And this is coming from a pretty big study. So this was commented on by another group who published this paper, something called Birth, which is home birth safe enough but not for the first baby. And basically what they say is that for an nulliparous woman, you don't want the incidence of having adverse perinatal outcomes are higher, and that you don't want to that it's more suggested that somebody should deliver in a hospital at least for their first baby. But they also discuss some limitations of the study. And the first thing is that they use a composite primary outcome of perinatal mortality and intrapartum related neonatal morbidity. So they just lump it all together. They have a number of events per 1,000 births, and they don't really delineate what those events were. And really, every outcome has equal weight. So an episiotomy versus an APGAR score, of less than 5 really has equal weight. And the reason why people put it all together is because you want to obtain adequate power. Also, that the place of planned birth impacts other choices that need to be made during pregnancy. Perhaps that may explain differences between the differences noted between hospital birth and home birth. So it really has nothing to do with the location; it has to do with other choices that can confound the outcome. Then there were a whole bunch of secondary analyses. This looks at the duration and urgency of transfer in births planned at home and in freestanding midwifery units in England. And what they wanted to do is they wanted just to look at how many patients were transferred from the outside units, and how fast were they transferred, and how fast did it take them to deliver the baby. So, thus again, looking over here, these are patients. FMU is a freestanding midwifery unit. So, in terms of patients who were transferred, 58% of patients who were transferred. Of those patients here who were delivered at home, and in the FMU is actually even a little bit higher than that. And over here, this tells you the reasons why were patients transferred, and they divided by nulliparous and multiparous women, and it's just pretty interesting. You have here malposition, malpresentation, failure to progress, fetal distress, meconium staining. And really, meconium staining seems to be pretty high on the list, and perineal trauma seems to be pretty high as well. The rest of them seem to be relatively low in terms of the percentages. But you can see over here, at least in terms of nulliparous women, that 44% of those people living at home were transferred. In terms of the multiparous women, only 11.6%. Were transferred. If you take a look at the freestanding midwifery unit, so 35% of the nulliparous were transferred, and 9% of multiparous women were transferred as well. And the timing, how long did it take? This is in hours. So from home, for all transfers, it took about 4.7 hours. For the potentially urgent transfers, it took about, taking everything into consideration, the median time was about 5 hours. And in terms of arranging the transfer, that took about 20 minutes. So this here takes the time to the decision to transfer. This is how long did it take to actually transfer the baby. So this is in hours, and this is in minutes. So you can see that people get transferred relatively quickly. This is all the median. So if you take a look at the median, there's numbers less and there's numbers greater than this median number of minutes. The overall, taking it from departure to the first obstetric unit assessment took about 25 minutes from the time that the patient left the house to the time that she was evaluated in the triage unit. Took about 25 minutes. The amount of time to birth after transfer, before labor took about 3 hours. If it was an urgent transfer, it's about 1.6 hours, and if it was a non-urgent transfer, it took about 5.4 hours. So their conclusions were that the total transfer time from home or a midwifery unit is between 45 to 60 minutes, and is actually faster transfer from home than from a midwifery unit. Because they think because the attendees are more cautious when they're at home as opposed to when they're at a midwifery unit where they have more capability of intervention than at home. Nulliparous women are more likely to be transferred, and the impact of neonatal outcome is unclear, given that since the birthplace primary analysis found similar rates of adverse perinatal outcomes in planned freestanding midwifery units and alongside midwifery unit births, even though the urgent transfers can potentially be achieved within minutes, in the latter setting, because this one is connected to the hospital. So it's interesting that you would have similar adverse perinatal outcomes if one is much farther away from the hospital than the other. And then, this was an article that was just published in October, that what they did is they looked at a retrospective cohort of term singleton live births in the United States from 2008. They looked at 27 states using birth certificate data. They included singleton, term, and vertex babies, and they excluded everybody else. There were 12,000 planned home births, 2,500 were nulliparous, and 9,500 were multiparous. And there were 2 million hospital births from these states, 834,000 nulliparous, and 1.2 million multiparous. And here's looking at the hospital, some sort of the intervention, and you're comparing the hospital versus the planned home birth. You can see the operative vaginal delivery is obviously much lower at home, induction of labor much lower at home, augmentation of labor much lower at home, antibiotic use in labor much lower at home. And this looks at a neonatal outcome stratified by birthplace, attendance, and parity. And here you have a 5-minute APGAR score less than 4. If you compare planned home birth by a certified nurse midwife, the odds ratio is less than a hospital birth, but if it's a planned home birth by other midwives, the odds ratio is greater. Similarly, for a 5-minute APGAR score less than 7, planned home birth is 0.84 and by a certified nurse midwife, and the planned home birth by other midwives the odds ratio is higher. Ventilator support greater than 6 hours is higher in a hospital, and neonatal seizures are higher by planned home births. Doesn't matter whether the nurse midwife was certified or not. But NICU admission was lower for planned home births, either by certified midwife or other midwives. So their conclusion is that the planned home birth had less obstetric intervention, but an increase in neonatal adverse outcomes were noted with planned home birth, especially when the attendant was not a certified nurse midwife. This is a response to this article, which has not yet been published in AJAC, but it's available online. And they had a few problems with the study. And they said that the study accounts for less than 50% of total births in the United States in 2008. It excludes large states such as Illinois and New York. It's up to the attendant to enter birth data. We know that these forms are filled out incorrectly. And stream marks on the birth certificate data sheet that we all fill out upstairs can cause false positive reports. So I just want to ask you if you can just tell us a little bit about the difference between the midwifery freestanding and long-term midwifery units before we get to the committee opinions.
So the midwifery unit, there's a couple of different ones. You explained it really well. I mean, there's the inpatient midwifery unit, which is kind of an in-house birth suite, which is kind of an ideal setting when you've got something separate from labor and delivery, but literally down the hall in labor and delivery. And so it can have exclusion criteria that you would have all low-risk normal births until it becomes abnormal and then you can transfer as needed. The freestanding birth centers are similar, and they may be across the street from a hospital. Ideally, that's the type of setting. It's not going to be really far away because I worked in one in Illinois or in Arizona, which is just literally across the street from Tucson Medical Center. So, but they have very strict criteria. So part of it is you're going to risk out a whole lot of women before you even start. And then there's differences between the midwives. One, there's certified nurse midwives who are advanced practice nurses, the same as level of nurse anesthetist or nurse practitioners. They're at least masters. Most of them are now going toward postmasters or doctorate. And they have a certifying body that you have to be able to have to get certified. There is a certified professional midwife. Those are the midwives that most of the time you hear about with home birth. Certified nurse midwives can do hospital birth, freestanding birth center, or home birth, but only less than 1% in home birth. Certified professional midwife or professional midwife are the ones that strictly do home birth. They can't do hospital birth or birth center birth. And they're the ones that a few years ago were in the news in Missouri that now they are legal to practice, and they do have a certifying body. They had a 2-year educational program, and they do have to become certified by their certifying body, but they're not certified nurse midwives. And so those are the majority of home births we hear about. Then there's a third layer of people that do home births, and they're considered lay midwives, and those would be basically apprentice types that maybe their grandmother was a midwife, or maybe they're in an Amish community, or they don't necessarily have any professional training. They just learn by the people ahead of them. So those are they have no legal.
Thank you. So now I'm going to go more towards the committee opinions and some of the ethics behind home birth. So in 2007, the Royal College of Obstetricians and Gynecologists came out with a summary, and they say that the Royal College of Midwives and the Royal College of Obstetricians and Gynecologists support home birth for women with uncomplicated pregnancies. There is no reason why home births should not be offered to women at low risk of complications, and may confer considerable benefits to them and to their families. There is ample evidence showing that laboring at home increases a woman's likelihood of a birth that is both self-satisfying and safe, with implications for her health and that of her baby. So this is the ACOG of England. In 2011, after the first two articles were published in AJOG, so ACOG also came out with a committee opinion that they reaffirmed in 2013. And they say that although the Committee on Obstetric Practice believes that hospitals and birthing centers are the safest setting for birth, it respects the right of a woman to make a medically informed decision about delivery. Women inquiring about planned home birth should be informed of its risks and benefits based on recent evidence. Specifically, they should be informed that although the absolute risk may be low, planned home birth is associated with a 2 to 3-fold increased risk of neonatal death when compared with planned hospital birth. Importantly, women should be informed that appropriate selection of candidates for home birth and the availability of a certified nurse midwife or certified midwife or physician practicing within an integrated and regulated health system. And there needs to be ready access to transport to hospitals. And then they quote some of the information. They gave this table that was from one of the article that I mentioned, and they focus really on this, about the neonatal deaths from non-anomalous babies. When you think of planned home birth compared to planned hospital birth, the odds ratio is 2.9. They do though show how the odds ratio for planned home birth is much lower for episiotomy after the vaginal delivery, 3rd or 4th degree laceration, and maternal infection. The American College of Nurse and Midwives came out with a statement as well, and they write that every family has the right to experience childbirth in an environment where human dignity, self-determination, and the family's cultural context are respected. They have a right to an informed choice regarding place of birth and access to safe home birth services. Certified nurse midwives and certified midwives are maternity care professionals who are qualified to provide ongoing assessment of appropriate birth site selection over the course of antepartum, intrapartum, and postpartum periods. And they are also qualified to provide antepartum, intrapartum, postpartum, and newborn care in the home. And then in the body of their statement, they write that recently well-designed controlled trials and descriptive studies have demonstrated that planned home births achieve excellent perinatal outcomes. And then they go down a little bit lower, and they say, unfortunately, some studies that have not differentiated between planned and unplanned home birth, or attended by qualified versus unqualified attendants, and or have not used clearly defined appropriate inclusion criteria for analysis, have been used inappropriately to discredit all home birth. So in 2011, Howard Minkoff, who's now the chair at Maimonides, discussed about what do you do, what's the physician's ethical obligations when patient choices may not necessarily agree with what the physician preference happens to be. And they focus on home birth as an example. And they write there that their intention is not to advocate for or against home births. But, since we're discussing it, they say that available studies indicate that home birth is associated with low absolute risk of adverse outcomes, but studies differ in the magnitude of the relative risk of complications as compared with hospital birth, and that weighing benefits and burdens should focus on absolute risk as opposed to relative risk. And the absolute risk of an adverse outcome from home birth is low, and it's actually congruent with the risks accepted for other choices, including trial of labor after cesarean delivery. So Frank Cervenek and Lawrence McCullough are two ethicists. Dr. Cervenek is up at Cornell, and Dr. McCullough is down at in Baylor, but they actually work pretty closely together. And they come out, Planned Home Birth Professional Responsibility Response. And basically he says that home birth puts mothers and babies at risk if a complication arises. And that the conclusion of the English Birthplace Study that says that these results support a policy of offering healthy and nulliparous multiparous women with low-risk pregnancies a choice of birth setting is totally irrational based upon the results of the study itself. And also, for some reason, the authors include the actual events in an online supplement not part of the main manuscript. And they think that planned home birth is unethical and should not be offered, and that the alternative is to create a home birth environment in a hospital setting. And this is from the supplement from the English Birthplace Study, and here they discuss the primary outcomes of stillbirth and early neonatal death and neonatal encephalopathy, and they discuss here you can see the obstetric unit versus versus home and freestanding and alongside midwifery units, and you can see that for stillbirth, the home events is about double. The risk is about double that of the obstetrical unit. Neonatal encephalopathy is a bit higher at home. Meconium aspiration syndrome is a bit lower at home, and everything else is pretty similar. So then there was a bunch of responses to Dr. Chervanek's article over here, and they say first of all they agree with Dr. Chervanek's article, and they don't like the use of the term prospective uncomplicated delivery because the existence of such a delivery can only be confirmed retrospectively. And also, they don't, there was the discussion, they were concerned about the network of private midwives, as compared to certified nurse midwives, as a type of a status symbol. And also, they were saying that if somebody wants to get a home birth, a patient really wants a home birth, you can tell them, at least as a physician, that you're concerned about jeopardizing one's clinical career in case anything goes wrong. So you can use the illegal liability card. Then a second person came out. This is a guy who does deliveries, I think, out in California, and he says absolutely. He says I'm not going to read the whole thing, but although I really should. He basically is a big proponent of delivering at home, and this is the response. And they say that this person claims that the criticism of planned home birth from the perspective of professional responsibility of obstetricians does not succeed. And they basically go on and they say that long story short, they vehemently disagree with everything that this guy says, and they try to discredit him. Then there was a midwife response that discusses different rights of women. And this is, again, a very, very biting response by Dr. Chervanek, and he says that we thank her, she's a PhD, so we thank Dr. Dixon for her letter in response to our article. And according to the New Zealand College of Midwives worldwide website, she is a midwifery advisor, practice, and advice and research for the college. And as much as she does not appear to be an officer of the college, we assume that she speaks only for herself and not also for the college. And she says that Dr. Dixon's presentation of our position distorts it beyond recognition. We know her adopted discourse of fetal rights. Indeed, we explicitly reject it. So they, again, somewhat of a big fight, and really, it's really, I think, worthwhile reading the actual responses back and forth. There happens to be pretty strong language. And then there was an article from one of the midwives, and he discussed all these different articles that were published in AJOG. And long story short, they came along and they say that the article by Dr. Chervanek is a report by 5 doctors, although one of them was a PhD. And AJOG is prescribing one birthing option for all women in all situations. And they bring in a quote. So Dr. Chervanek brings a quote where actually was a big advocate for home birth. And long story short, she had a home birth and she died. It wasn't exactly clear why she died. They think she had a postpartum hemorrhage. But at least at the time that this article was written, the cause of death was unclear, and people die in hospitals as well. And this is my favorite. It says, AJOG articles are nothing more than publicity stunts created in an effort to not forfeit even a small amount of business to competitors.
I just want to point out that's from the today.
Yeah.
That's
Medical Journal. Yeah. It sounds like one. But you can all like it's on PubMed if you want to read it. Then the American Academy of Pediatrics came out with, well, how does the world of pediatrics feel about it? And long story short, they say that they agree with ACOG, and they affirm that hospitals and birthing centers are the safest settings for birth in the United States, while respecting the right of women to make a medically informed decision about delivery. And they say that there needs to be specific criteria for a candidate for home delivery. First of all, you can't have maternal disease. Second of all, you can't have a significant disease during pregnancy. It should only be a singleton. It should be cephalic, and it should be between 37 and 41 weeks. The labor should be spontaneous or induced as an outpatient, and the mother should not be referred from another hospital. And there needs to be, again, you need to have your attendants to be certified, and there should be at least one appropriately trained individual whose primary responsibility is the care of the newborn infant. And he or she needs to have ready access to consultation, and there needs to be assurance of safe and timely transport to a nearby hospital with a pre-existing arrangement for such transfers. Yeah. At the end. Yeah. And they also suggest that anybody less than 37 weeks should be transferred by definition. The infant should be closely monitored after birth for at least 2 hours, whether or not it is premature. GBS culture should be obtained, and antibiotics should be given if appropriate. Screening for glucose imbalances or hyperbilirubinemia should be done if appropriate, and universal newborn screening and hearing screening should be done as well.
Sorry, we can also say that you can't make physicians do what they want to do. I mean, I think being in a place, in residency and fellowship, I had a lot of midwives that patients who were born at home and they often didn't want to come in. It wasn't the midwife fault. Even in the hospital, I had my fellowship my first 2 weeks, babies at ECMO solely because the mother refused to have a section despite 3 or 4 midwives plus the hospital plus everybody telling you they needed them.
Yeah.
No matter what we say and what we do, you can't make the patient do what they want to do.
It's true. I think we have it every place. I don't know if we've all seen.
With the patient not taking their medication, let alone where they're going to deliver and how they're going to deliver.
Yeah. We're going to discuss that, and you're 100% right. So comes along Dr. Chervanek and Dr. McCullough again, and they come along and they disagree with this committee opinion from the American Academy of Pediatrics, and they say that the American Academy of Pediatric Physicians should be consistent with what is in the best interest of the child. So it's a child. The plan-to-home births are associated with low APGAR scores, increased incidence of seizures, and an increased risk of neonatal death. And how is it in the best interest of the child? And they suggested in this opinion that was written also in pediatrics that the Academy revised their opinion. So then the people who wrote the opinion, they come along in the same journal, the same edition, and they say, we strongly disagree with Chervanek et al. That the American Academy of Pediatric policy and statement on plan-to-home birth diverges from its own primary principle to promote the best interest of the child. And they basically say, no, we agree that it's safer to deliver in a hospital compared to home. And we agree that pediatricians should counsel patients as to the risks of home birth. However, they say that the fetus is not an independent being before birth, and forcing a mother to give birth in a hospital takes away her autonomy. And safe birth does not always mean that a birth took place in a hospital, and an unsafe birth does not always mean it took place at home. And that there are valid differences of opinion about what constitutes the best interest of the child. And so we bring us to January 8th, 2014. And I'm very interested to hear what the audience has to say.
Most complications that end up in the hospital from home births What about still babies that are transferred and then those transferred to this hospital?
So it depends upon the study. So some studies excluded those from the outset, that they didn't include them in the criteria. If it was a patient who was transferred at home, so if they analyzed it by intent to treat, so then it would be counted as home birth. If they didn't analyze it by intent to treat, then it would be counted as hospital. Yeah.
was and younger is they're in the hospital right now. They had to run down almost 50 years. Oh, yeah. No. In fact, they don't do the hospital on the corner right there, so much higher. So I think getting to in pregnancy situation that you might transfer them. A lot of them will think that it's not going to happen to me. I'm not going to be able to transfer. And it's a very high rate. You know that. I don't know that yeah, if you tell your patient that in midwife, it's sort of analysis for whenever you're trying to track.
And I think that the midwife has a responsibility if they feel uncomfortable with that. We said certain criteria before the baby and food, and so I'm not going to say doing a home birth or a birth in a birth. Because, I mean, you have to have that discussion that sometimes you don't know until they break their water at 36 weeks or Mahoney and saying at 37 weeks, then they become a sort of period of the first period of pregnancy. But,
the comment I'd like to ask is the one about blaming the woman, or basically saying the woman, putting the onus on the woman to make choices. But really the problem is that she doesn't have optimal choices. And I think that's very true. And we have not responded, I think, to women's request for a more natural service. When I trained, there was still, in one of our hospitals, we still offered one-to-one nursing, intermittent auscultation. And for a variety of reasons, that is no longer a viable option for, I think, the majority of women who are and most of it, I think, is financially driven, and then you didn't even touch on medical legal, and I don't want to go there, but we have not responded to women's questions. And I think we have but we don't. Here, right? No, we don't at all. I think you get people who walk down the hallway. Right. So it's a cultural issue, and I think that there are going to be crazies who are not going to listen to anyone. We've all encountered them, and that's really unfortunate. And sometimes they die. The good news is that most of the time we get away with it. And the reason why I personally would not consider home birth is because I don't want to get away with it. But I wish that we did have a more welcoming culture in this hospital to really emphasize natural process and lack of separation of baby and that's a culture that is our responsibility to try to build with this approach.
And interesting that I mean, you've been here for you see many your abilities to communicate.
I think personally that the best case scenario is to have a little more separation. I think it's really hard for people to feel like the woman in 507 is different from the woman in 512, and so therefore she is no good. She does not need to she does not need her daughter broken. She is laboring on her own, as opposed to someone in high risk and really is a whole scenario. So my thought, and I think it's down the road, is to have some sort of a birthing suite, which is inclusion criteria is run by midwives or people that want to do low risk birth, and that it's just a different mindset than when you've got a laboring woman right next to a very high risk patient, and it's hard. And I really applaud the residents for trying to do that, but it's not a completely different thing, and there's a lot of people.
I like to go off, and it can be done. I've been in hospitals who do it midwife in the same area, and it's not ingrained here. So like I said, even when I try to let person can walk, no, they can't actually continuously monitor. No, they don't. Yes, they do? And because then we need to prove, okay, Dr. Rose, is it okay to remember? Listen, Dr. Rose said, okay, we have to stop our call. This is what I get into.
And I was in a birth the other day that even the nurse was like, she had a woman, as she was pushing, a third person came into the room, which was the mother or mother-in-law, and she made one of the people leave. She said, only two people can do this.
And it's so
And this woman was pushing it, it was completely normal, and it was fine, and she's like, that's the rule. And I think there's just a lot of,
what they've done for so many years, it has to be.
Right.
And they don't know right. No, they don't.
Like you don't
too much intervention can be
right.
Well, they're not saying that show up. Court gas doesn't hurt anybody. That's not.
And that's what somebody who wants to be covered with permanent and we get a continuously monitor. She's normal otherwise. She's still high risk solely for preterm after 38 weeks. She does not need to be continuously monitored and active. You know, they can't get out of that money.
But we don't have staff, and then and that's the other thing. When they're mixed together, the staffing required breaks, lunches, and meals, and everything else. There's a lot of cost cutting, and so how do you get your head around if you're looking after 20 weeks or a severe preeclampsia, and then the cost covering out because it's not covered because that whole intermittent consultation, natural birth really requires. And it's just, and when my patients want that, what I tell them is that, we do have a policy for intermittent monitoring, but it's really subject to staffing. You can't have, and I don't want you to have intermittent monitoring unless you have a designated provider in your room. Because you get sidetracked, you're blinking 45 minutes or something, and then that's when you get the next week, there's no documentation. And one of the main things about a home birth is, the midwife comes and brings her pajamas, and, she stays with the family. And that's, and that is, I think, amazing. And also fosters relationship. And that's the other thing that gives me stuff is a relationship between care providers and if you don't haven't developed any type of rapport relationship with a person, it's harder to meet not just their professional needs, but the needs around the creation of their family, which is very emotionally, psychologically powerful. Well, I think there's industry step by step. I was at Barnes the other day for a friend's delivery, and they had this huge, they're very high risk obviously too, and they had this huge policy out of clean skin and trying to stay clean skin for a certain hour. And my friend ended up with a primary section and he was in half the bar to stay with clean skin on the table. And that's at Barnes. And so I just feel like there are little things that we can do one by one, not necessarily have to go to there tomorrow. Huh? Well, I agree. I mean, the philosophy is immediately cancel forward and take the baby. Right. I mean, nobody asks her how much she wants. Right. I mean, the baby's bigger. Well, there are the baby leaving the cesarean section room because that is what nobody shows. Because that's like my pet peeve with the cesarean section. I'll stick up for the nurses. They have to ask for the patient. A lot of it's a patient culture. Like a lot of them want the baby comes off before they. Yeah, but I think that they have been asking for. They have been asking. This month they have been
started. They have to get in month.
Yeah. So sometimes a lot of these decisions are more politics and medical legal than they are medical. And actually started there at the same time. The Barnes really built a separate low risk need. But what came out in the paper was that we were practicing racist obstetrics because the people who were candidates for the low risk unit were primarily African American and low risk, and we received by midwives and that. They really were our low
time to fix. But I mean, there's a lot to learn from those experiences going forward. And I think as obstetricians, our when do you want to have?
So you see,
there's a potential for building in rehab in our near future.
so this discussion didn't discuss hospital issues, like how many possible deaths and what have you do we have over here. The reality is, back in the 1900s, most people delivered at home, and then then in the 1950s, less than 1% of deliveries were at home, and there was a reason for it because you could intervene. But the question is, you always have this pendulum in obstetrics in many areas. One of them being, our interventions for birth. It would seem this in my my limited experiences reading the articles. It seems that people want the environment to be more mother friendly, and it seems as it should be that we don't want to give up our safety of having surgical intervention if we need it. So it would seem that it would be correct to do a low risk unit run by midwives, certified midwives, with who have access if they need it, and just to let us know where I was in Houston we had it, and if there was an issue, the patient becoming pre-eclampsia or eclampsia, then they get transferred over. Which happened more times than once. But that way you have the maternal environment that they really want. You can have, I don't care, if they want to use a bathtub with a midwife, so fine, bathtub, whatever. But that's the midwife unit. But if there's an issue, then you can move them down the floor or down the hall or what have you, and then you come to the regular traditional unit, and that way you'll have the patient safety and the patient satisfaction, and then your Gini scores goes up, and then we go.
As a physician, you can still do that kind of.
You can, but it's a culture, like you said before. It's all.
But we need to change the culture, because that whole concept of midwives do this kind of delivery and doctors do this kind of delivery we need to break that culture down, because.
I understand. It's a while.
They're teachers as well.
Absolutely. I mean, I think
that'd be great.
Obstetricians, if people don't have access to, I want to say both times, but both models, that never get the benefit from knowing that there's other right ways to do things.
So I don't know. Absolutely, you should actually really. The middle happens to be great in terms of. I think in terms of low risk, they probably do a much better job as we do as obstetricians, like a much better job. But the question is when there's somebody in this business of birth at 90% boring and 2% terror, and the question is, and you have to be able to transfer from the 98% to 2% like that, because that's what the patient's doing. Yeah. Yeah, but he's right. But it's true. I mean, yeah. It's on YouTube. You can get it.
Let me tell you that they got away with it. That there is an absolute right. But I'm just saying, watch it, because there is a got away with it. And I wrote I went to the website and I wrote something, and of course it's never interesting. But I would have loved to have seen the movie, which they had got. And there was probably would never have been.
And what you don't say about Ricky, first of all.
She's a VBAC.
Well, VBAC. Oh yeah, I don't know her physical history, so. Yeah.
But we also, as a community of obstetricians, we induce too much, we intervene too much, we are still paternalistic in the way we deliver care. And this is a bad group to talk to, because we only deal with high-risk people. So our people don't even qualify for this kind of thing unless they happen to grow out of their preterm labor. Those are the only people who are really low risk. But in terms of the low risk population, we don't give them a low risk experience. There's too much intervention. They everybody gets monitored, too much monitoring, they get too much too many inductions and too little.
They don't eat, they don't get the shower, they're sitting up for hours.
There's always a small percentage of women that home birth. Always want that that's not going to go away. And so, there's so many issues, hundreds of different issues discussed. But I think if you focus that there's always that group still there, regardless of what happens. We just have to do the best we can for these patients. Because we're going to do that. So many issues. And legally, politically, and few years ago, the test was going really, I think it was late. They looked at practice without having to have insurance, not their own insurance. And that test, with the 11th hour, power of the session, and you got to catch another bill, it's kind of good when you went through that. But so there's so many political things and potential legal things, but I think the focus should just be developing people's future.
As a physician, do you think it's really liability insurance off of a no certificate not members?
I don't think they're insured with co-pay.
Same members.
Well,
You
should have your own personal liability.
Do you ever done homeless? No. In Haiti every year. You have friends who have. Are they insured?
Yeah. And any nurse midwife who does home birth have collaborative and then a plan, and they have really strict exclusion criteria. So I think the people that most come to the hospital that are the disasters are the people that are without a plan or was legal and they said they were doulas and it was just, that's the perception that a lot of people see in a hospital because they see the worst of the worst.
Or the patient is ready to feel sometimes there's financial influence as well on people who don't have traditional insurance and may not also have Medicaid. This doctor who too hard, took care of these women well through these plans. And basically did all the prenatal labs that we could that was free. And we only saw the complications. We didn't see the hundreds and hundreds and hundreds of normal births. Yes, he was. Yeah. And it often brought them in personally, without admitting that he was going to attend a home birth. But we all knew it, and that's where it was.
There was this organization in Chicago called the American College of Human Services. When I was a medical student there, I remember that they didn't talk to us. They had a group of doctors that were very close to births. But I don't know if they still exist or not. It's interesting. The website, I don't know if they still exist.
I know my friend that Marlene in Florida, and she had a midwife collaborative with the physician in Florida. He had been talking to the kids and I helped her.
Great.